Okay, everyone. So welcome to session 3 for the Scleral Lens Soiree, which is advanced scleral lens designs. And no one better in the industry to talk about this than Dr. Denayer. I am your host, Dr. Stephanie Wu, and I will be moderating this session. And now it's my pleasure to introduce a good friend of mine, Dr. Greg Denayer. Dr. Denayer received his pre-optometry education at the University of Nebraska in Lincoln, Nebraska. Soon after, he attended college and received his Doctor of Optometry from the Ohio State of Optometry. And then he was eager to continue his education. So the next step was completing a residency at a hospital-based optometry clinic at the Chillicothe VAMC and Columbus VA OPC. He has been practicing at Arena Eye Surgeons for over 19 years with an emphasis on specialty contact lenses. He is the co-founder and past president of the Scleral Lens Education Society and also a fellow of the American Academy of Optometry. Dr. Denayer is an internationally recognized contact lens specialist, and he has delivered many different lectures and workshops at over 70 conferences. Dr. Denayer has been a huge inspiration to me throughout my optometry career. He has helped me a ton with all of my scleral lens questions throughout the years. So it is a true honor to have him on our panel. And we're so excited that you're here today with us.
Dr. Wu, thank you so much. I really appreciate that. And thank you for inviting me for this lecture today. Really appreciate being here and hope everybody can get something out of it. And as Dr. Wu mentioned, my course is on advanced scleral lens design. And with a time limit of 50 minutes, I do have to limit what we're going to discuss. And so today, I really want to focus in on instrumentation and measurements that we can use to fit custom scleral contact lenses more efficiently and also with improved success. And I will be talking about the various instrumentations that allow us to do that, as well at the very end, we'll go through some case examples to put all of that into action. The instruments that I'm going to discuss this afternoon include, maybe somewhat surprisingly, corneal topography, optical coherence tomography, or OCT, Scheimpflug tomography, and finally corneal scleral topography. Well, most of us fit scleral contact lenses using diagnostic trial lens sets, and this is Scleral Lens 101. And we use these diagnostic lenses in our clinic to, number one, determine sagittal depth, the depth necessary to properly vault the corneal surface. We use them to determine the geometry that's necessary in order to get a proper vault from limbus to limbus. We definitely use them to determine the landing zone that we need to have an even bearing surface across the bulbar conjunctiva. And then, of course, we use them to determine power or the lens strength we need for the patient to see their best. And oftentimes with this process, we're just choosing a lens to start with. We're placing it on the patient's eye, and then we are determining the vault that that lens provides, the limbal clearance, and then, of course, the landing zone that we have. And I think as we all know, there's a fairly steep learning curve to this process, especially as we start to fit and use these lenses on more complex eyes. And this is a well-known study now that was first published as a paper at the as a poster at the Global Specialty Lens Symposium, and then later published as a paper by Dr. Araujo. And what they were looking at is how many cases would it take a neophyte scleral lens fitter in order to become efficient at fitting scleral contact lenses. And what they found is that it took around 60 cases for the practitioner to become efficient with scleral lens fitting. And when you think about that, it's pretty interesting because if you are new to scleral lenses and you're starting out and you're only fitting 2 to 3 lenses a month, that calculates to a potential 2 to 3 year time frame in order to become proficient with scleral lens fitting. And in fact, actually, if we look at part of the mission statement for the Scleral Lens Education Society, that statement starts out, the Scleral Lens Education Society teaches contact lens practitioners the art, and emphasis art, and science of fitting scleral lenses. Well, we now know that instrumentation and measurement allows for less art and more science. And in fact, actually, we can use instrumentation, we can use measurements to empirically fit custom scleral lenses. This is published data actually from an article that came out in a contact lens spectrum article this month from Dr. Ed Bennett. And this really highlights what we were just talking about, is that the vast majority of scleral lens fits are fit using diagnostic lenses. Only 10% right now are empirically fit. And when we look at sort of a standard bell curve of adaptation to technological development, we see that we're very much in this early adapter phase of accepting this technology, of using this technology. And as we move forward and as more practitioners use these devices, use the software, we're going to see increased success. Well, the first instrument I actually want to discuss this afternoon is corneal topography. And we're all familiar with corneal topography. Most of us should have these instruments already in our office. We use them diagnostically to detect disease such as keratoconus. We use them to follow up patients with corneal disease or issues. We also use them to empirically fit corneal gas perm contact lenses. But one question we might have about corneal topography is, can scleral toricity be predicted from corneal topography? So can we use our measurements from corneal topography to help us fit more advanced scleral lens designs, such as incorporating toricity? Well, this has actually been studied quite a bit, at least initially, through small pilot studies. And most of this data really showed that there was not a relationship between what was happening on the corneal surface and out onto the sclera. Until we had this paper by Consejo in the 2018 cornea edition, and that paper, Scleral Shape and its Correlations with Corneal Stigmatism, did show a relationship. But one difference between their study and the previous studies that were done was that they used corneal scleral topography. And their conclusions were that corneal and scleral shapes are correlated in astigmatic eyes, which suggests that astigmatism is not restricted to the cornea, but should rather be considered a property of the entire globe. And so this is what I see in my practice, but there's a couple key points here. What we see here to the right is an elevation map of the cornea, so out to 12 millimeters. And you can see these blue areas out here towards the limbus. And we're going to talk a little bit about this more, but these blue sections actually represent areas of steepness or increased sagittal height. And if we superimpose the scleral elevation map, which is out to 20 millimeters, we can see that there's this puzzle piece effect. So we have the cornea, and then we have the sclera, and we see a continuation of the steepness from the limbus of the cornea out onto the sclera. And so when you're evaluating corneal topography, we need to, number one, look at the elevation map, which is usually a function on most of your topographers. So instead of looking at the power map data, we switch to elevation map. And then secondly, we want to look out towards the limbal zone, because that's the area that's going to be really connected with that scleral surface. Second question we can ask about concerning corneal topography is, can scleral shape of a keratoconic eye be predicted from corneal topography? Well, in 2019, the Scleral Shape Study Group published a paper looking at the potential relationship between keratoconus and scleral shape. We looked at 83 eyes that had central ectasias, or what we would term as nipple cones, and then 114 eyes with peripheral ectasias. And what we were looking for is to see if there was a relationship between the location of the apex of the cone and scleral asymmetry, which we actually termed as a quadrant-specific effect. And what we found was there was definitely a relationship there. And in fact, the sclera generally tends to be steepest in the same axis as the apex of the cone. And this is quite helpful. By the way, this data actually was just recently assessed as well in another study by Dace, and they found the same correlation, that the steepest area apex of the cornea was correlated with the steepest region of the sclera. And so this is how this might look. If we look at a three-dimensional model of this keratoconic eye, and we find the location of the steepest area of their cornea, what we tend to see is that their sclera is steepest in that same axis. And the consequence of that is that, of course, if there's asymmetry or quadrant-specific effect, that the landing zone of, like, let's say a spherical design scleral contact lens won't fit quite as well. And additionally, this causes the lens, the scleral lens, to slide downhill. So we'll get inferior decentration. So when we do corneal topography, again, elevation data is good, but in this case, we can actually look at power maps. If we see an eye that has a peripheral ectasia or keratoconus, then we can assume that their sclera potentially may be steep in that inferior quadrant, and that may require a quadrant-specific type design scleral lens. So a lens that has a steeper landing zone in the inferior quadrant in order to have the lens center more effectively, and as well as create a landing zone that has more even bearing. Okay, the next instrument that I want to discuss is optical coherence tomography, or OCT. And those of us that are optometrists or ophthalmologists out there, we're obviously very familiar with OCT. In fact, most of our practices, either private practice or institutions, have OCTs, not for assessment of the anterior segment, but we use it for assessment of the posterior segment, either the macula or the optic nerve head and nerve fiber layer, because we use this to track macular disease or glaucoma. But many of these instruments do have a anterior segment option, or typically an auxiliary lens that we can add to the device that allows us to evaluate the cornea and potentially the fit of a scleral contact lens. And so mainly we use the OCT to help evaluate a diagnostic lens or a fit already dispensed contact lens in two main ways. Number one, we can use the calipers to determine very accurately the fluid reservoir thickness, and so we can make adjustments from there as needed. We can also swing the device over so that we are able to measure out onto the landing zone and make adjustments as appropriate there if we see edge lift, or if we see that there's excessive compression. And I'll tell you too that these measurements, especially those measurements out onto the landing zone, can be quite helpful for the consultants with the manufacturer that you're utilizing. So if you have those images available and you're having a hard time with the fit, and you're able to get those images to the consultants, that can be quite helpful. Some of the challenges, though, with OCT and using that type of instrument for scleral lens fitting and design are, number one, is that we just have these single meridian measurements at a time. So it can be kind of time consuming or quite exhausting if we're trying to take 7 or 8 measurements around the eye on a particular fit. And then also, at least currently right now, there's lack of software modules for direct lens fitting. Dr. Gamoulis, though, is a practitioner, scleral lens fitter out of Texas, and he has developed his own personal system. This isn't anything that's commercially available, but his own personal system for fitting very highly customized scleral lens designs using OCT. So if you want to learn more about what he's doing, you can visit his website at laserfitlens.com. Okay, now we're going to head more into the meat of the lecture. And with the next two types of instruments we're going to talk about, you're going to see that we're really able to use these instruments, these measurements, more directly for our lens design and fitting. And those two categories include corneal scleral topography or Scheimpflug tomography. And when we're using these measurements, we're able to, number one, match our scleral lens design with corneal shape. So we can assess the cornea and first decide whether we're going to use a prolate type of scleral lens design or potentially an oblate lens design. We can use the measurements to measure the bulbar conjunctival scleral surface, and then we can match that lens or those measurements with the type of design we may need to fit for that particular eye. And that's assessing whether or not the scleral surface is spherical or toric. We can look at scleral obstacles and, of course, also measure scleral asymmetry. And then, as I've already alluded to, there's lots of software now available that we can use with the measurements to fit and customize either a branded scleral lens design, or now we can either fit these free-form scleral contact lenses. Well, let me first talk about corneal scleral topography. And of course, we've had corneal topography for decades now. And unfortunately, those placido-based instruments, those reflective instruments, are limited to just the cornea surface. But now we have had some recent technology advancements that allow topographers not only to measure the cornea, but out onto the scleral surface, sometimes up to 22 millimeters in diameter. And truly, this has been a game changer, both for us to be able to understand scleral shape, to measure scleral shape, to study scleral shape. But then, as you'll see, we can now use the measurements from the entire anterior ocular surface for lens design and customization. From corneal scleral topography, we're able to obtain a number of measurements, including, and sort of not limited to, mean sagittal height of the eye at any selected quarter diameter. We can measure sagittal height at a specific location. We can measure scleral toricity very accurately. We can also measure scleral asymmetry. There are two devices that are commercially available right now as far as corneal scleral topographers are concerned. This is the first one, the SMAP 3D corneal scleral topographer. It is fluorescein based, so we have to add fluorescein to the ocular surface for the instrument to recognize the clear tissue of the cornea and the bulbar conjunctiva. The SMAP requires 3 gaze measurements, and that's to help get under the lid measurements. It can assess the anterior ocular surface out to 22 millimeters in diameter, and it has software capable of fitting a customized branded scleral contact lens design to the eye or a free-form version. The second corneal scleral topographer that is commercially available is the eye surface profiler, or known as the ESP by Eaglet. It is also like the SMAP fluorescein based, so it requires fluorescein for measurement. It only utilizes a straight gaze measurement. There's a number of measurements done and the best measurements used, but it's only straight gaze. And it can measure out to 20 millimeters in diameter. You, as a practitioner, can use the data from the ESP to help you more customized diagnostic fit lens, but they also have something what's called Direct Connect available, which allows you to use the data with up to 9 different manufacturers to fit more customized scleral contact lens designs. And then finally, we have the Scheimpflug tomography or tomographer, and this is of course known as the Pentacam. Nothing new, the Pentacam has been around for a long time. And we can use it to highly and accurately measure the cornea, and uniquely, not only the front surface, but out to the back surface, which helps us sometimes with early detection of keratoconus. And then we can also use that instrument to measure global pachymetry. But now, and this is more recent, the Pentacam is, at least some models, does have the capability of measuring and assessing the scleral surface. So now we're getting a more complete anterior surface measurement. Something that's different with the shine fluid tomographers are, as compared to corneal scleral topography, is that these units don't require fluorescein for measurement. And there's 5 measurements taken when we're going to assess the sclera. So there's one that's taken for straight, and then there's 4 more taken for the other 4 quadrants of the eye: superior, inferior, nasal, and temporal. But the eye still, in each of those measurements, is in straight gaze. And we can measure out by using this instrument to 18 millimeters in diameter. Again, not all models of Pentacam have this capability, but the ones that do, you can you basically use this corneal scleral profile module, CSP. And with that, then after the measurement, you can use the software to assess, again, the entire anterior ocular surface of the eye, sagittal height data, scleral toricity, and there, again, ability to use this data, these measurements, for more customized lens designs from various manufacturers. Okay, now I want to jump into some case examples. Case examples where we are fitting more advanced types of the designs, and we're using instruments, we're using data to help us with our efficiency and success. So for this first example, this is a 52-year-old male patient of mine that came to me with granular dystrophy. And this patient had been for years wearing bandaged soft contact lenses, number one, for protection, because unfortunately with granular dystrophy, the surface can get rough and they can get these punctate epithelial erosions or abrasions that cause them some significant discomfort. And with these bandaged lenses, by the way, that did have power to them, including, actually, I believe one was a toric soft contact lens. His visual acuity was 20/50 in the right eye and 20/80 in the left eye. Well, as an interesting aside as well, I had previously fit his mother, who also has granular dystrophy, with scleral contact lenses. So that's what this patient was interested in: scleral lenses for improved protection of his anterior ocular surface and also potentially improved vision. Well, for this patient, we decided to use corneal scleral topography maps to help fit the lenses for the patient's eyes. And we, like I said, you can actually just use the measurements that you obtain from the cornea and the sclera to help you with diagnostic lenses. And this is the right eye elevation map of the patient's cornea. And I mean, there's really not much to see. There's his dystrophy makes his cornea slightly irregular, so not a lot of data there. But overall, we can assess and know that his corneas are prolate in shape. So if we're going to use a diagnostic lens from our office, we can pick a prolate design rather than oblate. And then we can look at his scleral elevation maps. So what we see here to the left is his right scleral elevation map, and to the right is his left eye. The center circle that is red in both of those maps and is outlined by a black line, that's his cornea. And for right now, we're just going to ignore that. So everything that's the color arrangement that's around this circle is all of this sclera out to even a little bit farther than 20 millimeters. And something to keep in mind too with elevation data is that in general, the blue colors or the cooler colors represent areas of increased sagittal height or steepness. And the warmer colors represent areas of decreased sagittal height or areas that are a little bit flatter. And this is sort of counterintuitive of what we are used to looking at or seeing with power maps, where the steeper section is typically the warmer colors. And the first thing that we can look at on the right eye is that, generally speaking, that color pattern of the elevation map is quite uniform. In fact, actually, his right eye is a spherical shape. But when we look to the left eye, it's completely different. So we have these areas of blue obliquely, and those areas are areas where the sclera actually is steeper. So steeper, and it has increased sagittal height. And so for this eye, we can say that the sclera is actually toric. And even if we didn't use anything else with the measurements and the data, just having this information for this particular patient really helps us with efficiency and potential success, because if we don't know in advance that his right eye is spherical, that his left eye is toric, and those of you out there that are just diagnostic fitting, how difficult that could be to sort out. So just instantly knowing that we're dealing with a right eye that's spherical, a spherical scleral shape, and a left eye that's toric is quite useful. Now, for the left eye, beyond just knowing that the sclera is toric, but also has an oblique presentation, we can also measure the amount of toricity. And in this case, out to a diameter, a core diameter of 16 millimeters, we know that a sclera is 255 microns toric. So from here, even if we're just going to use diagnostic lenses, now for the right eye, we can grab a lens design that's prolate, that has a spherical landing zone, and we're able to choose that and put that on the patient's eye. For the left eye, we want to actually choose one that's toric. And most of the diagnostic lenses from the various manufacturers out there now carry or have toric designs available. So we want to grab a toric one for the left eye, and we know that the amount of toricity is around 255, so we can get something close to that. Now, something additional is that we can use the software in this particular case to know the sagittal height of the diameter that we're fitting. So in this case, 16 millimeters or 16.5 millimeters. And so that is also helpful too, because then we can even more specifically grab a lens that's over 4,000 microns for both the right and left eyes. And by the way, just sort of a pro tip as well, when we're talking about toricity, and sometimes even if you aren't able to measure it, the average amount of toricity at approximately 16 millimeters for either the normal cornea or for or even for eyes with ectasia, keratoconus, is around 200 microns. So that is sometimes helpful to know in advance. For this patient, the final fit scleral lenses, we used a spherical design, nicely vaulting over the corneal surface. And then in the left eye, we see here, again, nice, even haptic alignment using a toric landing zone. The patient is 20/40 and comfortable and happy with his scleral contact lenses. So we're able to achieve that right away with one fit. So again, using corneal scleral topography, even for a diagnostic lens fit, we can use those measurements to determine geometry of the cornea, or at least of the scleral lens that we're going to use, either oblate or prolate, depending on the corneal shape. Then also the landing zone. And in this case, we were able to determine right away that the landing zones were going to have to be different between the right and left eyes, and then also sagittal height. And ultimately, this improves our efficiency. For this next case, I'm actually going to use a case from my friend, Dr. Jason Jedlicka, and it's on troubleshooting scleral lens design. And that's going to be a theme here for some of the next cases, where we have patients that maybe not doing great with their scleral lenses or failed in scleral lenses. And we're going to use measurement from instrumentation to help us sort through that. So his patient is a 61-year-old patient who came in for a scleral lens evaluation. She'd actually been wearing scleral lenses already for 2 years. She was very satisfied with the right eye, but was complaining of discomfort and fogging of her left eye. The slit lamp exam evaluation did show a misaligned landing zone of the left eye, and debris was seen flowing through that area of edge lift. And so Dr. Jedlick had offered to refit her in a more free-form design lens from measurement. So the first thing that he has to do for this patient is have the patient not wear their scleral lens, and at a minimum for 48 hours. We know that scleral lenses rest on the bulbar conjunctival surface. They settle in, they of course then change the shape. So what we're looking for is when we're doing an evaluation or a refit is that we need that bulbar conjunctiva to rebound to its more natural position, its more natural state. So at a minimum, 48 hours. I know that the other practitioners, other experts would recommend even longer periods of time, maybe 3 or 4 or 5 days. I mean, really sort of the longer up to a point, the better. And what we see is that he measures the patient with the pentacam, and we're using the CSP module. And what we can highlight and now start to understand is that for her left eye, she's got this area or this quadrant specific effect between 1 and 3 o'clock that's really most likely causing the trouble with her previous lens design. And so what we can do is we can use that knowledge to refit her scleral lens so that it more evenly aligns to the surface and prevents those issues. So Dr. Jellica then uses software to design a more free-form scleral lens for the patient's left eye. He is able to use the software and recommend a corneal vault that he would like to have. And then the software is able to basically design a lens, changing the base curve, the limbal clearance, the landing zone of the lens to achieve the desired fit. Now, as far as the power is concerned, he didn't even have to put another lens on the patient's eye because he was able to use and calculate the power from her previous lens, which she was seeing fine with. After going through that process, the lens is electronically ordered. And that is really what is interesting about these instruments and the software is that depending on the device, you can electronically order these lenses. You're basically just uploading this directly to the manufacturer. And so it's quite easy. It saves you a phone call. It's very efficient. The lens on the eyes, you can see fit perfectly, ended up having a vault, a fluid reservoir of 300 microns with now an even landing zone alignment. So the scleral landing zone is able to take into account this asymmetry temporal, and she certainly has improved comfort and function with her freeform scleral lens design. Okay, I want to talk and spend a few minutes on pingueculas and in one case on pterygium. Pingueculas, of course, are very common and I think commonly problematic when we're fitting scleral contact lenses. And so let's go through a case example of that for a patient with pinguecula. This is a keratoconus patient that I inherited, a 53-year-old male who had previously failed in gas perm contact lenses. And then many years ago, I had actually fit him with scleral contact lenses, but he failed with scleral contact lenses. And the reason he failed was because he was getting severe midday fogging with the lenses. I mean, he would literally tell me that he would take his lenses out up to 30 times a day to rinse and refill them. And he did that because that was the only way that he could see. Well, eventually we actually refit him in a hybrid contact lens, which for a a time he actually was successful with. But then after a while, the lens tightened down on his eye. You can see this is his right eye, that the lens was basically compressing onto the corneal surface there. And so I discussed with the patient that, since we previously fit him with scleral contact lenses, that we have this new technology, we're able to measure his eye. And I suggested that we retry scleral contact lenses. And so that to start, we have him out of his hybrid lens for a week or longer. And then he comes in and we measure his eye using corneal scleral topography. This is the corneal elevation map, and you can see that he obviously has keratoconus with an oval apex, inferior located. Superimposed, this is his elevation map of his sclera. And what we're able to measure out is that in the area between those two arrows, he has 600 microns of elevation change there. And so we can already predict that that was probably what was causing his issue with his previous design years back. And in fact, actually, if we use simulated fluorescein fitting software, it shows us that it predicts that we get edge lift in that area. And when we have edge lift, this certainly can lead and be an entrance port for bubbles and debris. This is his map in the very center, and it correlates, this yellow area correlates very well with this nasal pinguecula. And in fact, actually, right now in this photograph, he has a scleral lens with a spherical landing zone, and you can really see the impingement there. And then just below that, the steeper area, again, cooler areas represent steepness or increased sagittal height. We see edge lift. And so this undoubtedly was the problem with his previous spherical lens design, scleral contact lens. So now what we're able to do is we just really use the software to design a free-form scleral contact lens that allows that edge or the landing zone to properly vault over the pinguecula, preventing impingement, and then coming back down more inferiorly of that to prevent the edge lift that leads to midday fogging. Now, something to keep in mind is that when we add these, basically these vaults over in the landing zone, that the lens has to be rotationally stable. So his lens is rotationally stabilized just by the free-form nature of the design, matching up the landing zone like a puzzle piece to his eye. There's a black dot indicator on the lens so that the patient knows rotationally in space where to and how to apply the contact lens. In this case, the black dot goes at the 6 o'clock position. This is another patient with corneal ectasia and a pinguecula. And this patient came to my practice. He was frustrated. He wasn't seeing well. And he had previously failed in a scleral lens with another practitioner. So the first thing that we do in our office is that we measure him with corneal scleral topography. And what we see here is a couple of things. Number one is he has significant scleral toricity. So we're going to have to deal with that. And then secondly, he has this nasal elevation. Again, this is the right eye. And very much like this last patient, if we look at the map and we see this elevated area there, it corresponds to very nicely with an area that's raised, a pinguecula, that's about 200 microns in elevation. And so for this patient, like the last patient, really we need to create a more free-form lens design and utilize, what we really term as a localized vault. So that's that area there that has a little dimple there. And again, there's a black dot to indicate the position of the contact lens for you to put the contact lens in, or the patient. And then we can see that when it's placed on his eye, we nicely vault over that pinguicular surface, no impingement. The patient with the very first lens is immediately comfortable and successful. And he was thrilled. And these are the patients that really help build your practice, because you've shown them very quickly how successful they can be. Here's the black dot at the bottom. You can see as the patient looks up, and he is 20/20 and very, very happy. Okay, the next patient. This is a patient who has history of pterygium, 61 years old. He had a number of surgeries to remove the pterygium, and including 2 amniotic membrane treatments. He has a lot of residual astigmatism. He's 20/30. He wants actually a contact lens for golf. And we had tried a soft contact lens to start, but he failed with that, secondary to poor vision. And this is his elevation map of the cornea. And you can see he's got these steep areas here. And like I had mentioned, we're able to see here that there's this match between the corneal toricity and what happens out onto the scleral surface. So he's got significant amount of scleral toricity. In fact, actually, when we measure it out, he has 508 microns. So that's over double, remember, of what we consider to be average scleral toricity. And then he's got this asymmetric area here from his previous pterygium and pterygium surgery. If we put a scleral lens with a spherical landing zone on his eye, we can predictably get impingement nasally. And so that's going to be a problem. So again, for this patient, we're able to take the measurements and design a more customized scleral lens. And here's the lens that we designed for the patient. You can see just how irregular the lens is, which really matches the patient's ocular surface. This is the lens on the eye. Nice, even landing zone. The patient is successful, doing well. If we look a little more closely and nasally, we can see that there's this nice vault over in that area. And we're really avoiding the impingement that we would normally get if we were just defaulting to a scleral lens with a spherical landing zone. Okay, then for case example, I just want to finish up with conjunctival blebs, because this is certainly falls in the realm of advanced fitting. And for blebs, we can either use notched lenses or localized vaults. And it used to be that, I would fit notched lenses, and I would have a diagnostic lens in the office that I would use to help me with measurement, and then basically communicating with the lab about what I needed. But now we can really use, again, software to help us with a notch. So this is a case example of a patient who had full thickness corneal transplant and secondary glaucoma. It's a fairly moderate to severe conjunctival bleb after trabeculectomy. And we can use the scleral elevation map not only to measure the bleb, but find out if the patient has significant oblique scleral toricity. And the software, really, we can use it to first measure the amount of toricity needed, and then the amount of lens that needs to be beveled out for the fit. And so this is the fit lens on the patient's eye. We actually dial down a little bit in diameter so that we don't have to have as much bevel. So this lens is 15.5 millimeters. She's able to see 20/40. And it also incorporates a toric landing zone to even out the landing zone alignment. And then this last case, this is a patient with another transplant patient with a bleb post-trabeculectomy. We're able to map this eye out with using corneal scleral topography. Fairly significant bleb that we're going to have to deal with, especially with a scleral contact lens. For this patient, and really now, again, with the availability of measurement, I tend to use localized vaults or vault over those blebs rather than notches. So for this patient, we use the elevation map for a more free-form design, a 16.5 millimeter scleral lens. It has a customized landing zone that takes into account the entire shape of the scleral surface, which not only allows for better alignment of the landing zone, but rotationally stabilizes that lens position so it doesn't move off its position. And so that we can get this, and this is quite incredible, 900 micron localized vault to fit over top of that patient's glove. And so here's the lens on the eye. In fact, it fits so well, it's almost invisible. So I'll highlight it with this black circle, but you can see how nicely it fits on the patient's eye. It is, there is a black dot at the bottom to indicate the position for the patient as far as application is concerned. And then again, nice vault over that glove surface. And amazingly, with one lens, the patient is successful. Well, when I started fitting scleral lenses back in 2001, so now over 20 years ago here, incredibly, it was a bit like the Flintstones. And we really didn't know anything about the scleral surface. Scleral lens design was rudimentary. And so, we put up with a lot of poor fits, but it was still better than what we were often getting with corneal designs. And that's actually really what helped scleral lenses succeed and push forward. So even though it wasn't perfect, it was somewhat better than we would sometimes get with corneal Gaussian contact lenses. And now I think, especially as you can see through some of these case examples, we've really, I feel like we've gone from the Flintstones to more Star Trek. And it's only getting better from here. So it's really a fun time to be a scleral lens fitter. I just really want to spend the last few minutes just circling back around to these instruments and going over some of the highlights. So corneal topographers, almost required in practice for diagnosis of patients for fitting corneal Gaussian contact lenses. They're great because it is a billable exam. For scleral lens fitting, we can use the measurements from corneal topographers for deciding geometry, either oblate or prolate designs. And then, as you can see, we have some studies that show that we can sometimes predict scleral shape just from the cornea, either scleral toricity, if we look out into the limbus with elevation data, or scleral asymmetry with keratoconus. Some disadvantages of topography: no direct measurement of the sclera, and lacking measurement for more direct lens design. We have OCT. OCTs are great because they have lots of functional use in our offices, both anterior and probably, more commonly posterior measurement of the eye. Very billable, so good return on investment if you're measuring back surface of the eye. For scleral lens fitting, they're great for assessing fluid reservoir thickness and assessment of the landing zone, especially, again, these are great images to send to consultation. Disadvantages, it's one meridian at a time measurement, and we're lacking software for more direct design, and they're a little more costly in price. Corneal scleral topography, something more relatively new. We use them to measure both the cornea and scleral surface. We have these great elevation maps that allow us to evaluate not only the cornea, but obviously out into the scleral surface, 20 millimeters or more. For scleral lens fitting, we can use those measurements either to help us more efficiently fit diagnostic lenses, or we can take advantage of software to custom design either branded design scleral lenses or freeform designs. Disadvantages include, really, they're pretty much used exclusively for contact lens fitting. And, one thing I often hear about is space in our practices. So some practitioners have said, well, I just don't have space for another instrument and that type of thing. And so that can be a problem. They are more moderately priced. And then shine flume tomography, again, actually just really much like the corneal scleral topographers. We get measurements of the cornea and scleral surface now. The shine flume instruments allow us to measure the back surface of the cornea, which can be useful, as well as global pachymetry. They are billable exams, and we can use them to either help us with our diagnostic lens fitting and troubleshooting, or, as we saw with Dr. Jedlicka's case, for customized scleral lens fitting. Disadvantages, difficulty with measurements for patients with small eyes, and this is one of the more pricier options out there. Now, as far as your practices are concerned, when we look at instruments, when we look at technology, I think they're really important as far as marketing is concerned. There's a lot. I mean, there's more than 1,000 people on this webinar right now, so that really points to the popularity of scleral lenses. And if you want to fit more lenses, you have to compete, and part of that is just showing what you can do as compared to everybody else. And so these instruments, these measurements allow you to be more technology driven. You can post this on your website. Patients are really wowed in the exam room when you're showing them these images, so that can be quite helpful. And then from a business aspect, you have to look at the return on investment. And these are some things that you would talk about with your accountant, but you have to concern your budget, whether or not the instrument provides billable exams. But to me, the number one aspect of all of this is just the number of fits that you do. So if you're doing a couple of fits a month, then right now it may not be worth investing in this technology. But with that said, maybe part of your strategy is to grow and to fit not only 2 lenses a month, but 2 lenses every couple of days. And so you may want to make this investment as you think about the growth of your practice. And then, think about too, if you don't have some of this technology now, where do you fall on this bell curve? Are you an early adapter and are you using this technology, or, are you a late majority or laggard? And so think about that as you consider how serious of a fitter you want to be and how many of these that you want to do as you practice. Thank you very much. I appreciate all of your time.